Today we're going to talk about papillary lesions of the breast. So our disclaimer, the following presentation has been recorded live with current trainees of varying levels of experience with the subject matter. At the time of this recording, none of the trainees, myself included as the presenter, are specialists or experts in the material presented. The cases were not given to the trainees ahead of time, so all impressions are initial reactions to the tissue location and brief clinical information as requested. Comments and opinions contained in this video belong to the person conveying them at the time of this recording and do not represent the opinions or stances of either UHCMC or the Department of Pathology. Please be constructive in any comments concerning the trainees as they are still learning, and we want to encourage them to be inquisitive and engaged in their learning. Clinical information is a general guide and not associated with any particular case. The exact clinical information for the included cases is unknown. There are no follow-up stains or additional slides available. This presentation and associated whole slide images are available on pathpresenter.net. This presentation is not a substitute for medical advice. Please consult your physician with any questions related to your health. If you are a physician, please conduct research to ensure you are utilizing the most up-to-date information to manage your patients. Okay, so we have a couple of topics that we're going to go over today, and I probably should have in situ and invasive, not under benign, so keep that in mind. Benign lesions.
All right, so we have a couple of breast scores here. At low power, a little bit of more activity than you would normally expect. So let's zoom in and see what we have here. So this does not look like normal breast ducts.
Right.
It's very papillary.
Excellent.
Kind of looks like a brain, but that's beside the point.
A little bit, yeah.
So focusing in, so we have sort of these papillary projections. The cells on higher power, they're a little, crowded, but I think they're not atypical. I don't see any prominent mitotic figures or too much pleomorphism. They look relatively similar.
Uh-oh.
Maybe.
Okay.
I don't know.
So in breast, do we want things to look the same or different?
Well, judging from that leading question, I would say different.
Right. The way I always looked at breast, like as a first year, was breast looks terrifying, kind of like fallopian tube. It's terrifying on high power, and you're like, wait, that's normal. So we kind of want things to look a little different. We want them to be crowded, overlapping, like they're almost like a dog pile where everybody's smushed on top of each other, but still maintaining like myoepithelial layers where they're supposed to be, and generally like the polarity in this is maintained, right? Because that also helps you.
All right.
But yeah, these are hard.
But it seems like the whole lesion looks relatively the same. Like there's no heterogeneity in terms of local areas of lesion appearance.
Sure.
So judging from, let's check out this section. Just to be a good pathologist and make sure you scan everything. So this part I'm assuming is just not too exciting, so we're gonna pretend we scanned it.
Yeah, a little bit of microcysts.
Fatty tissue.
Yeah.
And then we're gonna just take a look at this real quick, just make sure there's nothing hiding here, which is always a good practice to incorporate.
Definitely.
Just a quick scan, go on low power just to cheat a little. But yeah, it looks pretty much the same as the previous sort of lesion. And so I would say this one's probably a introducto papilloma.
Okay.
Yeah. And we're gonna see here, it's more of the same thing. So,
More of the same, yeah. Okay, so you're happy with that? This is a papilloma?
Final answer, I guess.
Final answer, okay. Well, hold on to that thought, because I'm going to give you another case.
Okay. Alright, so again, more core, some blood in this time. a little more fibrous than the previous one.
Yep.
There are some like sort of duct areas that are sort of similar and low power to the previous case, just stained a little darker here compared to the previous. So this, I'm assuming this will be the area of interest.
That is the area of interest.
These
yeah.
are just normal glands. These are kind of funky, but yeah, they're a little more papillomatous. But let's go back to the more interesting part for now, and then we'll come back.
Yeah.
Oh, say hi.
If you just go up to that double arrow, that's like on the diagonal. Yeah, perfect.
Okay, so again, there's sort of these papillomatous lesion,
Yeah.
like sort of like the other one, at low power at least. I think that's just the thick section, right?
Yeah,
So-
it looks like it kind of got pulled up and
Yeah.
smushed and overstained a bit.
But this part, I don't know, it's kind of interesting because it looks kind of more I want to say it looks a little more different than like this area, let's say, it's a little more solid.
Mm-hmm.
And the cells, well, other than these, like, that kind of reminds me of my epithelial cells in like a UDH, for instance.
That's great because that's actually like cells that you can see in different lesions that like to mimic myoepithelial cells. But that's okay. And there's maybe some areas that are a little less complex that'll kind of give you a hint as to what you're looking at. Like maybe kind of more of this stuff. Yeah.
Well, these things are a little less crowded
Mm-hmm.
and more uniform, I guess,
Yeah.
compared to the previous one. So, judging from, what we were going over previously, I would say this is atypical for a breast,
Well,
maybe?
it's still okay.
Still okay.
So what we noticed with if you remember from last time that we met, those like slit-like spaces.
Mhm.
So when we have slit-like spaces, what do we call those proliferations
Slit-like spaces.
on the outside? Think about all our epithelial proliferations. So we have the punched out lesions.
Yeah.
That's our ADH. So when we have the slits.
Well, the slits are UDH.
Perfect. Yeah. So like this is a little bit of like epithelial hyperplasia, but the staining's a little funny, but like you can kind of tell on this view, more on the right side, the eosinophilia is a little more prominent. So I think you actually maybe have a little bit of like apricot change.
Okay.
But yeah, it does make it look a little funny. And you could argue whether there's some atypia or not. I let this one go, in my 30-second perusal. But see, like, I think like that's really nice where you see more pink, but they're still smushed, they're still crowded, so it's not ADH, right? Because ADH, it's kind of like everyone wants their personal space. But it's hard because with apocrine metaplasia, they tend to get more cytoplasm. Yeah. But okay. So what do you want to call this one?
This one.
Because I put them together.
So it's two lesions, right?
Mm-hmm.
So can I say introductive papilloma with a UDA?
You sure can. But I'd let you pass it with just introductive papilloma. You can sign these out as like involved by UDH or involved by florid UDH if it's extremely prominent. Excellent. Okay. So obviously, as with all breast lesions, they're going to be more common in women than men. There is some slight delineation between the large duct papillomas and the small duct papillomas, but mostly it's kind of where they are in the breast. So if we think large ducts, you're thinking like right at the nipple or right beneath the nipple, versus small ducts would be like kind of anywhere else. And so your large ducts, because they're already in a large space, so those ones you might see grossly, but maybe not. What else do I have in here? We kind of went over everything about the large duct papillomas. When we say something like papillomatosis, so those are usually patients that technically it would say like more than 2 papillomas, but really it's like they have papillomas everywhere. Like when you get the excision, it's just a sea of papillomas all over. And many of them might even be microscopic, and I don't have that in here, but microscopic would be less than 2 millimeters in size. And SDP, yeah, is also slightly notorious for having entrapped epithelial nests. So what happens is when they go in with the needle to take the biopsy, they track epithelium back. So then when you get the excision, it can be really scary because you're like, I have a biopsy site and I have some epithelium that's just kind of floating in the breeze. Is that carcinoma or not?
That also came up on the pre-rise.
Yeah, because it's a scary thing. And these things can be very heterogeneous, like up at the top. Like that papilloma has a little bit of everything going on. Like it's sclerosed in some parts and maybe has a little UDH in some parts. Like what's going on there? But you can tell it's all like one lesion and it's in a dilated space. You should see fibroblascular cores because there are papillary lesions where we won't see those. And you should generally have maintenance of that 2-cell layer. But when you start getting those epithelial proliferations, that's when it can get kind of difficult, because then we run into all the problems that we had at the last time we met. Okay, so high weight molecular keratins, so we're going to go over these quite a bit in this lecture, like which ones are CK56, which ones are CK818 positive, which ones will have myoepithelial, so that'll be like your P63, which for most papillary lesions is more helpful than like your SMA or smooth muscle mass and heavy chain or SMMHC. For papillary lesions, there's a lot of molecular, but pretty much if it's benign, they're going to be monoclonal because it's a monoclonal proliferation. And commonly you can see like that 16p13 loss of heterozygosity. And there are a couple more specific loss of heterozygosity that you can see either in benign malignant or simply in malignant disease. And obviously, like if we have anything associated with a TP53 mutation or deletion, then those are going to be more malignant. And the PIK3CA, AKT1, and NRAS mutations they can be present, but you don't necessarily have to see them. So this one, it really is the morphology that's going to help you. But you know, if you have these on core biopsy, they can be extremely difficult because you don't always get like the nice delineation. So papillomas themselves, this is that 1.5 to 2 times relative risk over a lifetime. If they have papillomatosis, the risk is slightly higher, but that makes sense because they already have more lesions and they're predisposed to more lesions. And pretty much if they're symptomatic, so if the patient has nipple discharge or it's painful or it's becoming very large, we'll take those out. If we see anything that looks like atypia, we'll take them out. But generally I would say like most of these end up getting excised, so then you can do a full examination of the case. Okay?
Alright. More breast tissue.
Mm-hmm.
There's some ducts up here, a little power. This looks like more just fibrous tissue. So I'm going to start here and see what we find.
Excellent.
Okay. So we don't have much to work with here.
No?
Not a lot. But let's see now. So first off, there's this sort of proliferation inside these ducts.
Mm-hmm.
They're kind of bridging across.
Yeah.
Don't really see a fibrovascular core at these levels. At least they're not apparent here. The cells themselves are relatively.
Are they similar, dissimilar?
I would say they're more similar than dissimilar on this thing.
Excellent. It's kind of hard because it looks like it got crushed maybe a little. But yeah, you start looking and you're like, they all kind of look like potatoes, right?
Yeah, like this row here.
Yeah.
Looks very similar. Like that's pretty striking.
Yeah.
Over here it's a little harder to tell. It's a little more crushed, but you know, once it spreads out, it does look a little more similar. Here it's just useless. It's crushed.
What about those?
These cells. It's a little overstained, but I don't know. I feel like these ones look similar here, but it's kind of hard to tell with, like these ones here. So and these look a little more similar. This string here.
Yeah.
And
what do you have right here?
That's a fibrovascular core, I'm assuming. Just,
yeah.
Yeah.
Little easier to see at lower power.
Yeah. I mean, this area looks more like a papillomatous configuration.
Yes. Perfect. Perfect.
Yep. So, are these two separate lesions, or are they?
I think they look like one lesion because you have this area that's up here, and it kind of wraps around here, where you can imagine maybe this is a frond sticking down, and then it comes into this stuff here that's kind of falling away.
Yeah. Okay. So I feel like we're still dealing with a papilloma. But you know, these. So if we're assuming this is the same lesion, it definitely looks different from the previous one.
Yeah.
And they're more similar.
It's like peas in a pod, like they just all look like their neighbor.
So, based off of that, are we in the atypical territory?
I think we are treading all over that line.
Okay. So.
There is one other little piece that's easier to find if you're at low power, because it's towards the bottom of the slide.
Yeah, I think.
Yeah, just that tiny little section there, and it's like more of that same stuff.
This one it's more like, look at these, just kind of wrap around little tiny beans. Yeah, and this one, so atypical papilloma.
I like that. I'm okay with that.
Okay, and we'll just pretend we scan the rest of the slide.
That was literally everything to see on the slide, because there's a little bit of papillomatous stuff that fell off over there. And that looks okay. So, yeah, I think you're good.
Okay.
Alright, so this is also known as introductal papilloma with ADH. So, pretty much all the information that's on here and a lot of what's in your handout is going to be the same as the ADH stuff that we had from last time. Because pretty much it's just like a reminder of like what constitutes ADH. Okay? So the differences that we have with papillary lesions are whether it's entirely atypical or we have focal atypia. So like you could mention that in your line, but pretty much if you had a biopsy with introductal papilloma and you're seeing atypia, then like make sure you mention the atypia, because remember that's a trigger for them to go in and excise. And for papillomas, WHO states that they are atypia that's less than 0.3 centimeters with low-grade nuclei. So that's a little different from when we're looking at regular breast, right? But pretty much your thresholds should be pretty much identical. These are relatively common, right? We see them all the time. And they tend to be middle-aged women. And can see cribriform. You can kind of see anything, but we saw a lot of cribriform in our case. And it's pretty much like I said, they're all potatoes. They're not all gourds, and they really like their personal space.
Something that's important during the COVID-19.
Yes, they are all social distancing.
Yes.
These cells are social distancing. Yes. ADH does it right. Okay. So this one, so you'll notice the difference between a papilloma and an atypical papilloma is our CK56 is going to be negative in this, and your CK8 and 18 is going to be positive. These generally are ER diffuse positive, so that's your ADH, right? Diffusely positive. And you're going to have that low-grade molecular phenotype, right? The gains of 1Q, the losses of 16Q. And pretty much for all these, just, the same differential as regular papillomas, papillomas with atypia, papillomas with DCIS is all those papillary lesions and everything else associated with either ADH, DCIS. Okay. And all this information, again, is the ADH information, because ADH itself has increased risks anyway. Okay, but the pictures are all papillomas, so you can appreciate that then. All right, in situ lesions.
All right, more pores, pretty fibrous. There's some ducts here that we're going to focus on for now. So over here, it kind of has that, a bit like what we were previously seeing, I would say. There's some punched out lesions at low power at least. And over here, this could be maybe a papillary like fibrous core, but let's take a closer look at what we see here. So it's coming out, so this is not what a normal duct should look like. The cells look relatively spaced apart, and they're relatively uniform, not really seeing those prominent weird like myophyllous cells that kind of stick out like a sore thumb. So I would say this is more probably along the lines of ADH.
Okay.
But there are these vascular pores here that suggest possible papilloma. But the major finding, I would say, is probably ADH within a papilloma.
Within a papilloma?
Yeah.
Okay. So I think all that is very good. So what's one of the things, though, that we need to consider when we're trying to call ADH?
The size.
The size. So I think low power, it's a little easier to kind of guesstimate. Like, obviously we don't have a ruler up there.
So a pore is about like what, 2-3 millimeters in thickness. So this look like it's thick.
And it has to be less than
2 millimeters.
Less than 3 millimeters.
3 millimeters. Okay.
So it's like,
So, question. So when looking at ADH and they're doing two different foci with like normal intervening tissue, when do you aggregate and when do you not aggregate for the purpose of the two?
So that's actually a really good question, and I think every person, every institution kind of has their threshold for that. But for something like this to me is one lesion. Like, you might just have like the duct is kind of swooping in and out, kind of like how prostate will do that. And they're really close to each other. Like, if it was like opposite sides of the core, then I would count those as separate. But this being this close, this is one lesion to me, and you can see here it's going off the core.
Okay.
So I
then
think
it'll
we're
be
above the 3 millimeter threshold.
So DCIS
Yeah.
with papilloma.
Yeah. So yeah, there's multiple ways to word this. So you could say like, because this is, how would you want to grade this if you're calling this DCIS?
Oh.
Because you said it looked like ADH, so.
Yeah, so probably low grade.
Okay.
It's not really having any necrosis, so it won't be a high grade like comedonal necrosis. And
Right.
the criteria, so it looks more normal, quote unquote normal, you know.
Right. Do you remember anything else that we use when we're grading DCIS?
I have, but it's escaping me.
That's
now.
okay. That's okay, because everything kind of has its own criteria, right? Excuse me. Yeah, as a disclaimer, I have really bad asthma and I am not COVID-19 positive. Okay. But, so we look at the overall, like, sameness, architecture, right, like pleomorphism. We look at, are the nuclei relatively the same size? And like you said, the necrosis, mitotic figures. So we take all of that into account with DCIS. And this is pretty bland as far as things go. So I think your idea of low grade DCIS is a very good one. If this wasn't papillary, then you could go into, well, what type of, like, what architecture of DCIS is this? And there's a few different architectures that I see in this lesion. But are there any that you want to point out?
Well, this area looks more like cribriforming.
Yes.
And then, I mean, this area looks more papillary. Sort
Yeah,
of
there's some papillary areas.
I don't know if there's any solid, maybe. It's kind of pushing it here, but no, not really. Anything looks overtly solid. Not quite.
Yeah.
No.
So I agree with that. I think you have areas that look more cribriform, areas that are papillary, and areas that are micropapillary. But the micropapillary could also be papillary areas that are just kind of falling off,
Yeah.
or cribriform that's just kind of, falling apart for whatever reason. And then, like, this is a really nice area here, because this is actually an area of the papilloma that's sclerosed now. So sometimes you can see that too. You can also have papillomas where they actually will twist completely on their stalk and they'll infarct. So there's things to keep in mind.
So does the DCIS with the papilloma warrant any difference in treatment compared to just the pure DCIS?
So they're going to do the same thing relatively. They're going to excise, and because of DCS, they're going to want wide, clear margins, unless the patient's like, hey, do a mastectomy, right? And then you still want clear margins, but pretty much mastectomy, you'd be done. Besides, like, your screening after that. But no, it's like you would treat this as like regular DCIS, because chances are, if they have DCIS involving a papilloma, there might be DCIS elsewhere in the breast, so, which may or may not show up, like may not have like a palpable mass, or maybe they did this because they had nipple discharge.
This is a more benign.
Yeah,
Yeah,
isn't that
so,
cute?
yeah. Just for comparison.
Yeah.
Ones are some more normal here.
Yeah.
So that and this weird bloated thing. Alright.
Okay.
I think, there's nothing else.
No.
Oh,
What is that? It's one of the cutest things in breast. I love looking
Very
at that.
pink.
It's very pink.
Capricorn metaplasia.
Perfect. Yes.
Kind of falling apart.
And actually, it even has, it looks like it has some panicell-like granules that sometimes you can see with apocrine metaplasia. No one knows what that means, but sometimes you see it, so don't let it freak you out. This one, again, the staining's kind of dark, but like it'll be like bright red like you would see in GI. Because yes, Monday I have a video going up for adenoid cystic carcinoma that sometimes also has that panicell-like eosinophilic granulations. Okay.
Okay. Something different. At low power, you can tell that there's a lot of just proliferation of something, cells, and pretty much everywhere in the specimen. The margins are clean, I think, if this one's coming close, but technically not that ink, so technically no. But that's beside the point. So going in here, so just just looking at this, it's very, there's a sort of like a papillary pattern to it, but within the papillary pattern there seems to be some, well,
We were talking about monotonous cells, right?
Yeah. It just looks very monotonous.
Yeah.
Punched out lesions. Well, it's a little more slit-like, but it's like kind of these areas are a little more punched out. So it is very monotonous. So that's probably the most striking of it, of the features, I guess. And it's really like, it's a very big area. This is way more than 2 millimeters.
Yeah,
So
definitely.
could this be a DCIS?
I like that. So again, if we're going to call DCIS, we have to grade it.
Grade it, yeah. So looking at these cells, there's not too much pleomorphism like anything. That one stuck out just a little. Now, remind me, is there a scoring system for DCIS in terms of like how many points?
So it's not really points.
I might be thinking of
kind
something
of again
else.
it's like a personal
Yeah.
threshold. Like there's metrics as to like how pleomorphic the cells must be to call high grade. Like
Yeah.
I believe it's like 3 to 4 times a regular breast cell, but pretty much it's like if they look wildly different, and you have like really weird mitotic figures, which in this there's
I would
not
say
many.
it's still low grade
Yeah.
because it's like, I mean, look at this field. It's pretty much just the planet of the clones, sort of, and there's no overt necrosis. The architecture is not too crazy. I mean, it's not normal, but it's not crazy. And in terms of patterns, there's maybe some cribriforming, some maybe micropapillary in there. Maybe some solid even. Let's see. I think what is this?
That I think is a little different.
Yeah, I think it's something
So
else.
there's a lot going on in this breast, but
Yeah.
I'm glad that you honed in on the lesion of interest.
This looks more like almost like adenosis or
Yes, right? Because we went over adenosis and how terrifying it can be.
Yeah.
And there's a little more of the papilloma.
Yeah.
And there's a little more papilloma. So this thing just kind of keeps going.
Yeah. And this is.
And there's some more
Yeah.
adenosis.
This
Yeah.
is- yeah. Okay. I thought that was part of the lesion at first.
Yeah, no, exactly.
Yeah.
At low power, yeah.
I guess this is the star. We're not going to take
Yeah.
too much away from it. All right.
All right. Okay, so this is also known as intraductal papilloma with DCIS, or DCIS involving papilloma. So just a preference as to whether you like one way or the other. And generally DCIS we see in about every 1 in 5 to 1 in 4 cases of screen detected malignancies. So even though we see it in adult women, and it tends to hover around that perimenopausal, postmenopausal, it actually will increase with age. So by the time you're looking at someone who's 80 years old, they're going to have twice the risk as someone who's like 40. Okay. Most often they see calcifications on mammography, so likely to get a stereotactic for that. And so all the top information about the microscopic is the same as what we have for the ADH, the papillary ADH, because why? It's exactly the same, it's just the size. So either you have something that's bigger than 3 millimeters and it's low-grade nuclei, or you have like overt high-grade nuclei and necrosis and all the other stuff that we were talking about. With DCIS, you can see mucin, and like, okay, it's frequently seen with cribriform, micropapillary, papillary, and clinging DCIS, so almost half the patterns you're going to see cribriform being the most common. And then for cheminonecrosis, because cheminonecrosis is one of those definitions that's like, what does that mean? And it's basically saying that you have extensive involvement of the central portion of your duct is necrotic, whereas you can have focal necrosis, you can even have single cell necrosis in DCIS. Yes, and communocrosis is associated with high-grade nuclei as well. Okay, lots of images of papillomas. Oh, this is the one that
Next
messed
one.
up.
Oh.
So we will go back to that. Yes, technical difficulties today where I could not organize my slides. It is something that they will fix, but for today it's kind of messed up. Okay, so DCIS, most of them are ER positive. Some of them can be HER2 positive, but do we do HER2 on DCIS?
Do we do HER2 on DCIS?
Do you normally order HER2 if we have a DCIS case?
I'm gonna say no.
No. And it's pretty much like, because if we have a HER2 positivity, well, what do we do with that? What does it really mean? Your ECAD adherent is going to be maintained, and why? Because that helps you if you're thinking, is this DCIS or LCIS? Your P63 obviously is going to be retained because this is an in situ carcinoma. And molecular, I put none there, but realistically it's like you're probably going to have your low grade phenotype, so your 1Q and 16Q. Okay, and here's your treatment for DCIS. So whether you do a mastectomy or they do lumpectomy, clear margins, plus or minus radiation, but they like doing radiation with DCIS because your recurrence goes down by half. And if it's ER positive, which most of them are, they can give tamoxifen if they want. And we noticed a big jump, right? So we went from like the 5 to 7% with the papilloma up to 20 to 30% lifetime risk of DCIS. So these women, like once a woman has a diagnosis of DCIS, they actually very rarely will succumb to breast cancer, and that's because they're going to be screened so much, so they're going to pick up stuff before it's a problem. Okay, oh wait, gotta go back. So now we go back to the slide, and this is the next case.
Okay. Very blue.
Very blue.
I'm assuming breast tissue. So let's just looking at some. Oh, okay. So I would say it's kind of like micropapillary kind of configuration. Maybe some cribriforming of these cells that are.
Now are these all potatoes?
That's what I'm evaluating here because I'm seeing some cells that are kind of stands out.
Up
This
here?
one.
What's that?
Which one? This one?
What's
Oh.
this?
That looks like a blood vessel.
Blood vessel? Okay.
Okay.
Yeah. And if you keep going, there's another one.
Mhm.
There's another one. So, do you know what the difference is between papillary and micropapillary?
Oh, micropapillary shouldn't have like
Yeah.
pores or whatever in them.
There, see, you don't even need me up here, you know it. Yeah,
Well,
so with micropapillary, we don't actually see fibrovascular core, so it's like counterintuitive.
I was just thinking. I was looking at these things sort of.
Mhm.
I was thinking micropapillary.
Definitely.
Yeah. But anyways, the cells look pretty similar. Going back, evaluating if there's, pleomorphism, increased mitotic activity. On this projection, it's a little hard to see nuclear features, but there does seem to be some cells that stand out a bit more, that are a bit larger
Right.
than others. So I would say, on the whole, even though they look similar, I think this is another, I'm assuming a DCIS case. It's hard to tell because the pieces are kind of, you will probably sign this out as, cannot rule out invasion probably if it's.
Yeah, you'd hedge on
Yeah.
these.
But let's assume this is DCIS. I would say this is probably an intermediate grade
Okay.
DCIS.
And what's the overall pattern?
So, blood vessels. So, papillary.
Go. Perfect.
Yep.
Yeah, so this is like a papillary DCIS. At
It's
least
huge.
at this. Oh yeah, they can be. remember, you can have DCIS that can be like, 10 centimeters of breast involvement or more.
Yep.
But yeah, like you said, this is a biopsy, so we can't exclude that there's some invasion somewhere. So, this would say something about like some sort of like papillary DCIS with papillary architecture. See note, and note, like, you could estimate the size. ERPR will be reported in addendum. Given the limited
in this
limited specimen, this measures up to this, and associated invasive carcinoma cannot be entirely excluded.
Yeah.
Something like that. Yeah, the wording is the most difficult part, right?
But
pretty
ultimately
much,
they're gonna get.
Yeah.
Cut that.
This is DCIS, so it's like they're going to be like, okay, you know what, we gotta go in and we gotta take this out. So they're going to excise anyway. But with your top line in your notes, you always want to convey to them, like, what do you want them to do next? So with this, we really want them to give us more tissue. We want them to go and do an excision. So you just want to make sure that you're indicating that for them.
Hence in this limited sample?
Yes.
Is that why they
yes.
use that?
And say this can't be excluded. And trying to keep them simple so that you don't lose them in the process. Okay, so all of this is the DCIS, right? So it's DCIS, so all the risk factors and stuff like that are the same. It's just this has different architecture. So I more or less want to highlight the different architecture in these. So you can see in the gross photo how we have a really well circumscribed lesion with all these papillary projections. Now, it would take a really massive lesion for you to see that grossly, but you could. And usually if you're seeing something that big, you can pretty much bet on it that it's going to be high grade. So with papillary DCIS, we are going to see those fibrovascular cores. You are going to see myoepithelial cells, but your myoepithelial cells are only going to be on the outside of that lesion. So all the stuff we had in that biopsy, you probably aren't going to see myoepithelium because we can't really tell where the lesion ends. The little pieces that we have that are more fibrotic and might be part of a capsule or like fibrotic stroma, we can't tell because it's kind of all detached. And one caveat to kind of go into like all these carcinomas is that endothelium really likes to sit out at the base of these tumors. So it can make it difficult to evaluate if your myoepithelium is there. So then P63 becomes your best friend because endothelium should be what for P63?
Should be, never used it for endothelium, so I'm gonna just guess here.
That's okay, 50-50 shot, right?
Negative?
Yeah, it's going to be negative. So, so like if you're like, I don't know if this is myoepithelium or endothelium, you throw P63 on it. If it's positive, then you know it's myoepithelium and you're good to go. All the great mimickers we have to deal with, right? So all this is exactly the same information that we had on that DCIS slide, just more examples of papillary architecture. So you can see like that bomb picture I think is especially lovely. It has both papillary and micropapillary. The micropapillary is more towards the actual edge of the lesion, whereas the papillary stuff is all in the center. So you can really appreciate the difference between is there a fibrovascular core or not. Just to, muddy the water a little more, right? Okay.
We like mud in pathology.
We do.
Alright, so more cores.
Of course, yeah.
Thing that stands out is right here. So let's zoom in and see what's going on. So, architecture-wise, first off, not normal. There is too much like weirdness going on. These sort of cells that are relatively similar. That projecting in here no blood vessels on these ones, so it's more micropapillary in architecture.
Okay.
Would you consider this? Well, this is probably like a stroma in between, maybe two.
And what about this? What do you think about that part?
This is. That's probably a papillary core.
Yeah. Yeah. So they can be highlighted, so you kind of see like, oh, there's a little bit here, a little bit there, but like you said, there's all this stuff.
Yeah.
There's no cores in those, right?
Yeah. Or these ones here.
Yeah.
I think. Yeah.
A little bit.
A little bit. Again, decently large, extending across. The cells do look pretty uniform, I would say. Maybe a little bit like non-uniform, but like no, like it doesn't look benign. That's the picture.
That's key.
Mm-hmm. So DCIS again.
Yes.
Maybe low to intermediate grade.
See this? Look at that. That's beautiful.
It's a calc.
It's a calc. Yeah.
Right.
Which sometimes are like so hard to find.
Mm-hmm.
But yes, DCIS. I'm sorry to interrupt you.
Low to intermediate grade. You could hedge a little on the biopsies, as I've learned.
Yeah.
And then if you want to go into patterns, I would say predominantly micropapillary this time. There is a bit of papillary, but I think predominantly it's a micropapillary.
Yeah. So, is this involving a papilloma or not?
It could. Like this thing, yeah.
Yeah, because even if we had papillary DCIS, it's not going to have something like that.
Big, okay.
Yeah. So that tells you, like, okay, like there probably was a papilloma here, and it's just been swallowed up by the DCIS. And there's a few more pieces if you drive around, but mostly it's like cystic spaces that have like the micropapillary parts that are just kind of falling off in them.
I'm surprised we haven't seen more of these in our cases here.
Well, so micropapillary, thankfully, is rare. And that's a good thing because anything micropapillary, with like one or two exceptions, is bad. So again, like this is all DCIS stuff, except for the microscopic on the micropapillary DCIS. So you get like these, they call them light bulb or drumstick projections. And like you can kind of see it more on that bottom case that we saw on the papillary DCIS, where it's kind of like they start off really thin and then towards the top they're really bulbar. But they still won't have the fibrobascular cores. So it's like a misnomer, really, that they're called micropapillary because there's nothing really
Technically
that.
not
Yeah.
papillary. Yeah.
It's like a pseudo-papillary, but you know,
I like
used
to
out
go
of
with the drumstick or mushroom probably, and keeping in, in sync with the
Mushroom.
pathology's obsession with food.
Food.
Yeah.
eggplantish, I don't know.
Yeah.
Okay, and then the surrounding duct usually lacks hyperplasia, so you're not going to see like the UDH and ADH, or even things like columnar cell hyperplasia, and they should be relatively flat. Okay, and all this again is the same as the DCIS. Yay. All right.
Oh, okay. So again, this is a nice lesion here of some sort.
Mm-hmm.
Going in, it's kind of like, it's almost like just these solid patterns sort of inside. So looking at these cells, these do not look healthy. Like it almost it reminds me of like something like a squamous cell carcinoma, like invasive squamous cell, just how, like, what is that? It's
I think there's a
blood vessel?
yeah, I think there's some better examples
Yeah.
later on, but yeah, you're going exactly the way I want you to. This is great.
Okay. So, first off, this is definitely something to be very concerned for.
Mhm.
Can't really tell if there's a myoepithelial layer. Maybe, like, it's a little, there's some retraction artifacts from it, but, so those are,
Yeah.
okay, those are myoepithelial cells, so we could say, and assuming they're all the same, so we're gonna still be at DCIS
Mhm.
for this one.
Okay. Okay.
It's more of a solid pattern, I would say, because of these individual, well, do we have like I don't think there is a nodular. Is there a nodular?
There is not. I want you to
Yeah.
keep looking around,
Okay.
because remember, we're doing papillary
Very-
lesions.
Okay.
And this is something you asked me about before we started today, so.
Oh, is this like a solid papillary?
This totally is!
Okay.
But it's like, once you see like the definite like vessels like in the middle of that solid stuff, and you're like,
Oh yeah, these ones
Yeah.
are better. These ones, yeah.
because it's too much, right? Like the atypia is just a little too weird,
Mhm.
and they look nodular, right? But yeah, we don't call them nodules. Yeah, like we don't call this like nodular carcinoma in the brasser.
I see. So this is what it looks like. Okay, it's good to match a name with the picture.
Yeah.
And it's TIS,
Yes,
Question.
unless
unless
when wouldn't we call it TIS?
when wouldn't we call it?
Yeah.
Well, if it's invasive, right? Which,
Exactly. So if you saw foci that were like obvious invasion,
Mhm.
then you'd be like, yeah, we're not going to call this TIS. But yes, that is the general recommendation, that you call these TIS, same as you would for DCIS. What else? Okay, so like, even though this is like they look kind of funny, it doesn't quite look like a DCIS, right? Like they don't look the same.
No,
The cells aren't quite
no.
as like the nuclei aren't as big and stuff. And I think if you zoom in, we might be able to get lucky and find some areas that kind of fit its moniker or alias a little better. So you'll really want to take a look at the cells themselves. Is it going to behave? Kind of. The cytoplasm maybe is not sticking around, so that's not helping us too much.
Look, it looks a little clear. Are we still?
A little clear, okay. How about the nuclei?
Oh, wait, no, this is not the spindly.
No,
like
it's
something
not.
else. Never mind.
It's not really behaving too much, and it doesn't have to have this differentiation, because there is spindle variants, which this might have more of that in it. But solid papillary carcinoma is also known as neuroendocrine DCIS. So sometimes it can look like a neuroendocrine tumor,
Maybe
but
a
it's
little
yeah.
smaller.
But I think what you were saying about the spindle, because it can have spindle cell type as well. So this might be just a little more spindle than neuroendocrine.
This is interesting because if you're used to just looking at DCIS and invasive ductal and lobular and stuff like that, and you look at this, you're like, is this even breast? Like,
Right, because
so
it makes you
it's-
pause, right?
Yeah.
Yeah.
So
But
think
I
that's-
this is probably a little more spindled.
Mhm.
There's some areas that look maybe a little more neuroendocrine, but it's hard to tell. But okay, so I know you did a little bit of reading about these and a little bit of learning about them. So are these good tumors to have or bad tumors?
that I did not get
Okay.
to, but say good.
Yeah. So these are relatively indolent. Excellent guess. 50-50 shot. Hey, you can't beat that. You're 2 for 2 right now. Okay, so these are uncommon. So this is why we don't see them, right? About 2% of breast cancer, and they're in older women, well, older adults, but again, we see almost everything in women. They're usually a single mass, but sometimes you can have multiple nodules that'll kind of just be like snowballed together. They're well circumscribed, like we saw in our example. They're very cellular, and they have those fibrotic bands that separate all the nodules of the tumor. So even if it's a single mass, it's like you still might have areas of fibrotic bands in between them. So they tend to have solid pattern, which we saw, and the fibrovascular cores are not always easy to find. Okay, we kind of had to search around for them a little bit. And in our example, the cells are like low to intermediate grade. They were more spindled. Didn't really have so much neuroendocrine. Didn't see any mucin, but you can with these. And your myoepithelium, again, is going to be at the periphery of the nodule. If you have papilla, you're not going to find myoepithelium in myoepithelial cells there. So your P63 is not going to be as helpful. We did talk about the T staging for these. You can also see pseudo-rosettes. Sometimes you can see mitotic figures, and the mucin we already talked about as well.
Now, is there a reason why the myoepithelial cells are not always present?
So, like with the papillary DCIS, you also don't see myoepithelial markers in like at your fibrovascular cores, but they'll still be at the periphery.
Mm.
So that
Oh,
kind
I
of
see.
is what's helping
I
you
see.
say this is in situ,
Yeah.
right? But you know, we see that with DCIS too, where you can have DCIS with microinvasion. So with this, you could also have invasion, even though it looks like it's well contained. Okay, so solid papillary carcinoma, we get into some different staining. So it can have neuroendocrine differentiation, right? So our neuroendocrine markers could be positive.
Hence the name. Like
Yeah,
the alternative name.
exactly.
Okay.
But if you were worried that this was a metastatic neuroendocrine tumor, your ERPR should be negative in a metastatic tumor, but it'll be positive in SPC. Okay? And your negative stains, okay, so P63 would be positive at the periphery, so that's kind of confusing how I wrote that. I apologize. But within the actual lesion itself, it's going to be negative around those cores. And these are HER2 negative, so you're looking at, this would be like in like the low risk luminal A type if you were doing like a mammoprint on these. And what you'll notice is as we go through, well, we didn't have a case of encapsulated papillary carcinoma, that's in your handout, but your EPC, SPC, and IPC, the genetics are the same, okay? So they're very similar, and we see those low grade, 1Q, 16Q, so again, when we're thinking like the luminal type A and B, that kind of fits there.
Remind us, luminal A is the one that are ER positive. ERPR positive, HER2 negative, and S100 negative?
Well, like the HER2 negative.
Yeah.
Whereas your B would be triple positive.
Okay.
Okay. All right. They're going to take this out, plus or minus radiation, and they're indolent. So if you had to have a tumor, this is probably the one to have in breast. Okay, invasive lesions.
Ooh.
Yeah.
Okay. Well, the first screen superficially at low power looks in situ, but we could be wrong because we're in invasion. Sorry, spoiler, right?
Spoiler alert, yes.
Yeah. So let's go in and see what we're dealing with. So again, it's a sort of papillary configuration. It doesn't look normal, so it looks like cells look pretty similar. So it's like a carcinoma of some sort. So if we're looking for invasion, then it means it has to invade. So I'm assuming somewhere there should be invasion, and there is some tumor out here.
Okay, what do you have here? It's going all the way around.
Oh. Wow. Okay. So these are tumor cells?
Some of them are, but if you zoom out, you kind of have a capsule, right?
Yeah.
And it's poking through that.
Okay.
So this little area down here, this is enough, right? Because your main lesion's up there.
Yeah.
This is coming
so
through.
I was looking at, this one.
There's some cells that just kind of percolate through, like you saw.
Yeah. So this would be invasive.
Go with it. Go with it.
Papillary carcinoma.
I love it.
Okay.
I love it.
That's very interesting. I don't think I've ever seen one of these before.
That's great because these are also rare.
But yeah.
No, that's excellent.
Yeah. No, I'm just saying we are in Cleveland, so what's rare is not rare here.
That's true. We could get a few of them next week. You never know.
Yeah. And they always comes in two, so.
Yeah, or more.
Strangely,
Or
yeah.
more. Yeah.
So invasive papillary carcinoma.
Okay. And before you read it on your sheet, are these good or bad? Compared to if this was just
An SPC would be good.
SPC is very good.
Uh-huh.
So if we were comparing this, say, to just your standard intraductal carcinoma,
Introductive. Well, I would say
since that's the most common.
introductive. Okay. Well, I would say the invasion makes it bad.
Right, but is IDC invasive?
It is.
It is, yeah.
It's in the name.
So do you think these behave worse than that or
IDC,
better?
worse than. Say better.
Man, you're on a roll. Go buy a lottery ticket today. Just, social distance while you're buying it. Yeah, so pretty much like even though we're going to look at treatment, excision, whatever we have to do, and you're pretty much going to do the same things as you would do for just your regular invasive ductal carcinoma or invasive carcinoma of no special type, these actually do better than grade matched IDC. Okay, so why don't we see them less than 2% of breast carcinoma? It's kind of a recurring theme, right? These are older women, and pretty much you don't get anything special on imaging. It's kind of like any other invasive lesion. It's just going to have irregular borders. It might just be a density. And grossly, it's going to look pretty much the same as IDC with regular borders, tan white if you're lucky, firm if you're lucky. If you're really lucky, you'll find that clip right away, right? But so what you need to see is pretty much the entire tumor has to be papillary. Because otherwise we would say something like with papillary features or something like that. So again, we're not going to have myopithelium associated with the papillae. And there again, I had the thing about the blood vessels at the base. And occasionally you're going to have a tumor cell that's P63 positive. So you need to be aware of that. They don't actually tend to have lymphovascular invasion or nodal mets. And when you compare them to a grade matched IDC, it's a significant decrease. When you're looking at 16 and 14% of cases having either LVI or lymph node mets, let's say this was a low grade or grade 1, if you had a grade 1 IDC, 35% of those cases would have LVI, and almost 50% of those could have a lymph node met. So the difference between those is quite striking. You can see DCIS associated with these. They're almost always low grade. Sometimes you have intermediate grades. So if you're seeing like grade 3, I would rethink this diagnosis. What they actually can confuse you with is papillary thyroid carcinoma. There's a tall cell variant that pretty much looks exactly like PTC, also the tall cell variant. So you think about all those things like the nuclear clearing, pseudo-inclusions, or like the orphan annuli and nuclear grooves. Well, you'll see that in the tall cell variant. There will be lots of semomatous calcifications, but there will be no DCIS. So if you're like, hey, this kind of looks papillary, like papillary thyroid, and there's absolutely no DCIS, then I would think about, is this metastatic PCC from the thyroid, and which stain do you want to do?
TTF PAX 8. No, sorry. No, sorry. I'm getting my bars here. TTF 1, I would say, and
That's a good one. What's another one that's thyroid? It's one that I always forget to think about, so.
I don't know.
So you could do thyroglobulin.
I was thinking, okay, I was just like, is that
I always forget about myself, and then someone mentions it, and I'm like, oh yeah, that one.
I was thinking of that. I was like, is that even a stain? I guess so. Yeah, I guess it is. Yeah. Okay.
So both those will be negative, so that'll help you. And what's really interesting about these is that they are cyclin D1 positive, almost all of them. Whereas your ER may or may not be positive. HER2 is almost always negative, but rarely can be positive. And again, we go back to our EPC, SPC, IPC, right? So the same type of mutations. There's not going to be BRAF or RET. So again, if you were thinking, is this thyroid, that will tell you definitely not. And like I said, we're going to treat it similar to invasive carcinoma, no specific type, or invasive ductal carcinoma, and it has a better prognosis than that. Okay, so it's just one of those ones to keep in the back of your mind, and just remember to, like, you can have metastatic lesions to the breast. It doesn't happen all the time, but it does happen. Okay, this is our last case.
Well, this is something ugly again.
Yeah.
Can't tell much from low power, but possible invasion. Looks like maybe it's extending to the fat here, if that's the same lesion, but we will find out shortly. Going in, looks ugly. Assuming these are not retraction artifacts, they kind of do have a papillary look, but without the pore, so micropapillary.
So how would you tell if this is retraction artifact or real?
You would.
Just if you know any tricks. If not, I'm happy to tell you.
I would say I don't know any tricks off the top of mind. I'm just thinking. Just maybe the lining. If there's, I don't know. Tell me.
Okay, so you had good ideas right from the get-go, and you kind of abandoned them a little bit. So with retraction artifact, it's going to be an exact mold to whatever shape it's in, okay? And the edges are always going to be smooth. So what we notice here is this isn't smooth, right? We have cells that almost look like they're hobnailing, right? They're poking out. So that tells you, okay, this probably isn't retraction. Something else that I think it's kind of hard to tell on this one, but when is there an area of central lumina? This might be okay-ish. So when you have central lumina, the apex or the apical surface of the cells, so where it's secreting, that tends to point towards the stroma instead of towards the lumen that's inside. This isn't a great example, and the cells are really big, but like you would think, like logically, like they should go towards that lumina, right? And they actually point out the other way. And that'll help you with some of the staining that you can do. But those are things that help you.
Okay, so we've established this is micropapillary then. There's no pores going through these. I mean, just on the whole, looks invasive because you can't really tell where is like the capsule on this. It's kind of just spreading maybe up here, but even up here in the fat here, we have this tumor. So this is most likely invasive micropapillary
Yeah.
carcinoma. Yeah.
Okay. So a couple of things. We do have lymphovascular invasion on this slide. Even though it's pretty close, like all these. Yeah, this is lymphatics. And there's some more. So there is some of it. But you believe it more if it's far away from your lesion. Micropapillary carcinoma typically does not have a capsule, which kind of makes sense, right? Because it's kind of just percolating through everything and just, you know, mass destruction as it goes.
Here.
Yeah, like you can see, it's just kind of everywhere. The beautiful thing about these is that, so even though they really like to metastasize, like to lymph nodes and in like LVI, they always maintain their architecture. So it doesn't matter where you see micropapillary carcinoma of the breast, it's gonna have that same architecture. Whereas like a lot of the other tumors kind of change how they look, right? So this one is good that way. It makes it easier when you're going through your lymph nodes and stuff. Yeah, you mentioned that we don't see papillae.
True papillae.
True papillae. Well, there's no fibrovascular pores at all. But yeah, these are just very, very ugly tumors that just kind of, you know, send a chill up the back of your neck. You good to go?
Yes.
Okay. So again, rare. So when it says 3.8% of breast carcinomas, that's saying as a component. So only about 1% are pure invasive micropapillary carcinomas. And these affect adults of all ages, but on average they're going to be 55 years old. So unlike a lot of the other tumors where we could say like most of these are going to affect like postmenopausal women or perimenopausal women, you could have like a 20-year-old walk in one day and an 80-year-old the next, and both have this. They may have calcifications, not always, and they tend to be a relatively good size, like, you know, about 2.8 centimeters on average, but like up to 10 centimeters of this stuff, so you can imagine like how firm that breast would be when you get the sample. And a third of these are multifocal. So multifocal, and this would have to be like you have like distinct separate lesions with normal breast in between. So that's why it's so important when we're sampling like a mastectomy and you're making sure that you're taking samples in between all the lesions. Because sometimes you can't tell on imaging that they're actually the same lesion. So they'll measure two different lesions, and then if we come and tell them, oh no, that's actually like one big lesion, then that usually changes the staging. Okay, we talked about a lot of the stuff, so plagenal cells, they may or may not be pleomorphic, hyperchromatic. The example that we have, they are very pleomorphic, very hyperchromatic. There's nucleoli everywhere, and it's very high grade. And the cytoplasm, where you could see it, maybe it's more granular. I think there's a lot more vacuolated parts. And then a lot of the things talking about the clusters I went over with you guys where there's no fibrovascular cores, so the blebbing, or we didn't really see, but like that's what you should see, is where the apical surface comes towards the stroma instead towards a central lumen, and you can have almost like a hobnail appearance. So you have to report how much pattern you're seeing, and to call it micropapillary, you have to have at least 3/4 of your tumor be that. And we talked about the mats with this, how it maintains the same architecture, so that makes your life easy. And so when we're grading, you don't use the empty cell clusters, so where it looks like it's forming a tubule, you don't use that for tubule formation, so most of them are actually going to be a tubule score of 3. So when you're looking at the tubules, mitotic figures, and nuclear features for the Nottingham scale, you're typically going to give this a T of 3. Okay, so positive stains. So MUC1 EMA, so those are different stains. We haven't seen those in our other lesions today. And they stain the apical surface. So they're going to stain like the outside of all those areas that look like they have lumen. They tend to be strongly ER positive. They may or may not have PR, and may or may not have HER2. And the HER2 has this partial membrane pattern, which I really should get a picture to show you guys, because with HER2, right, we want that diffuse, strong membranous pattern to be calling it positive, but with this tumor in particular likes to have a partial membrane pattern. So just to throw things off even more, as if it wasn't hard enough. Depending on the grading and your HER2 status, you're either going to have luminal A or B. The molecular is a little different, right? We start seeing chromosome 8 is in the picture, and we have lots of heterozygosity on chromosome 17. So that brings into mind like a few things, like your P53s and stuff like that. And obviously, because we have MUC1 expression by IHC, a lot of them will have MUC1 mutations. You can also see amplifications in MYC quite often, and once in a while your CCND1 or FGFR1 could be amplified as well, but those are a lot less common. Okay, so with this, they're going to excise, and you have to keep in mind that these lesions are at increased risk of local recurrence even after a mastectomy. And it kind of makes sense, right? They just kind of percolate everywhere. So even post-mastectomy, which normally we do a mastectomy and we're like, hey, you know what, we're done, we don't need radiation. These are patients where it's like you're going to be like, hey, let's radiate that chest wall and any associated lymph nodes. And you might remember from the NCCN lecture I gave a couple weeks ago, I guess like a month ago now, that the larger the size, the more lymph node areas we're going to consider to radiate. And this is micropapillary, right? So it's more aggressive than grade-matched invasive ductal, and we have frequent metastasis everywhere.
And contrast the papillary invasive, that's less than IDC.
That's less than, yeah. And I did put together a slide here to kind of show you the difference between retraction versus lymphovascular invasion, just so you can kind of see that. So what I was saying with the smooth edges and how everything conforms, so you can see how it's like the exact shape, and all the outside edges for the most part are smooth, whereas we look at the micropapillary and it's like, I don't care what you're doing, I'm doing my own thing.
It's in its own little world.
Yeah. And that's what I have. So there's 16 challenge cases for you. There were some really good cases in their bank, so even if you've gone through the cases and you want to look at more, there's quite a bit in there for papillary, so if you're not sure about these lesions, I encourage you to do that. And that's all I have for you this week, so thanks. Tune in next week where we'll be talking about stromal lesions of the breast.